こんにちは。オキュロフェイシャルクリニック東京院長の鹿島智之です。海外の先生を招いて海外の知見を日本のドクターに向けて講演していただくというインターナショナルレクチャーズの第2回目になります。今回のインターナショナルレクチャーズはジョンズホプキンス大学からニコラス・マホーニー先生に最新の 3D 技術を使った眼科手術と眼瞼下垂についてご講演してもらいます。アメリカと日本の眼形成の世界の違いを知っていただけたらと思います。それではマホーニー先生、よろしくお願いいたします。
Great. Well, thank you very much for taking the time to meet with me today. I'm visiting from the United States. My name is Nicholas Mahoney. I'm the Chief of Oculoplastics at Johns Hopkins at the Wilmer Eye Institute. I do a few other things there, including some work in data science, as well as train fellows in America. I'm also the Fall Scientific Symposium Director for ASOPers. So if you guys will be coming to ASOPers next year, I would love to see you guys. We always like to have a discussion about financial interest. I have no financial interest in anything presented today. We're going to talk a bit about navigation and virtual surgical planning. Some of the things I'm going to cover involve orbital fractures, so I'm just going to briefly touch on a few things I think are of interest in the way I think of orbital fractures. We know a lot about orbital floor fractures. I see a lot of this where I work in Baltimore, Maryland. Patients have contact to the rim, which buckles the orbital floor and creates a linear fracture line. And then the compression that happens of the globe will make some of the retropulsion of the fat kind of push out and decompress the orbital floor, which gives you some herniation of content into the orbit and the maxillary sinus. We've seen this for years in various diagrams. You see this in all sorts of pictures, although you'll notice that what they diagram here is a little bit different as far as what happens with the muscle and the fat. And I think these things are of interest, so I always like to cover them briefly for the way that I think about them. You know, Corneef, who was an oculoplastic surgeon in the 70s, nicely sort of demonstrated that there are these septations between the intraconal and the extraconal fat, as well as between the fat pockets itself. And when you look at orbital floor fractures, you can actually see that it's not just the bones that break. We also have a change in the orbital fat. And it's always intraconal orbital fat that we probably see below. And you can almost get a sense of this orbital fat kind of coming from the intraconal space around the inferior rectus muscle. In fact, you see it in all these different pictures. It's almost coming around, dragging the inferior rectus down. If you look at the other side, you almost never see fat below the inferior rectus muscle on these scans. Here's a whole bunch of other scans where you don't see fat on the contralateral side below the inferior rectus. So it's not just the bones that we need to restore. The intraconal fat is very important for the position of the eye. The other thing that happens was that muscle gets disturbed, as you can get some problems with the way the eye moves. We've demonstrated an increasing amount of double vision relative to how big the fracture is. Here's a gentleman who can't look up. He has a relatively large floor fracture. He has some intraconal fat that's been herniated. His rectus muscle is out of position. Here's a young girl who can't look up, and in this case, the bone is not displaced. And I always like to clarify when I'm talking to my colleagues in, say, radiology, that we really have four different situations here. You can have a problem where the bone is displaced and not displaced, where the fat is either herniated or not herniated, and then the same thing with the muscle. The bone can be displaced or not displaced, and you can have muscle that's herniated. It's really that bottom one where you have the muscle in the non-displaced fracture element that would give you a risk of something like muscle necrosis, and it's a much more urgent situation. But any of these could give you double vision, and the ones with displacement where the fat's allowed to herniate significantly are the ones that we often like to fix for volume, which is the majority of the surgery that I do. Volume expansion, if you actually count how much fat is there, it's not just the same amount of tissue in a bigger space. You actually have an increase in the volume of tissue. Probably those septations get violated and the fat actually bulges out. And so if you count up the actual volume, it's much bigger. The other thing I think it's important to think about when I consider orbital fracture repair and the sort of structure of the orbit are the implants themselves. We do a lot of different type of work with implants. And over the years, there's really been an evolution towards a more ideal orbital implant. And there's both titanium as well as porous polyethylene implants that are common in my practice, although there are some other ones as well, such as nylon smooth sheets. And over time, they've really evolved to add titanium into the porous polyethylene, which gives it rigid structural support. They've added some efficiency techniques to make it shaped a little bit more like an orbit. And they've added some additional things that get very complicated to really reconstruct the anatomy of the bones as accurate as possible. And these three sort of models in particular, I refer to as patient-specific implants. And you kind of have three different types that I'm kind of clumping together into patient-specific implants. You have the type that is titanium bent to a sort of orbital model. You have a pre-made orbital implant that's designed by a manufacturer to look like an orbital implant that matches the orbit. And then you have one that's 3D printed by a printer exactly in the shape that you want. And of course, to do any of these, you need to do a bit of work to do virtual surgical planning, which I usually refer to as VSP. It always starts with a high-quality CT scan, and then there are a few other steps in the process of virtual surgical planning that I think are very interesting and it's important to get familiar with. First thing we do is we create a virtual model. Step two is to smooth that model. So we don't want all of those sort of very thin bones to be poorly represented on the model. So we do some smoothing and interpolation. Then we do something called auto-segmentation that finds the bones. In this case, it actually takes an orbital model, a 3D model, and warps it to match the bones rather than actually just trying to find the windowing, because the orbit doesn't really show up very well, the medial wall on the floor at least. Then we do something called mirroring, where we take the good side and we mirror it over to the bad side. And then from there, you sort of do your virtual surgical planning. You can print it with a 3D printer and then bend titanium to it and then sterilize the titanium. You can print the model in a material that you can use intraoperatively. This is a case of very large fibrous dysplasia. We had a 3D model printed during the surgery and we just bent the titanium to it for a cranioplasty. Or you can use the 3D implants that come prefabricated. These are designed to match a variety of orbital shapes, although each one is slightly different, and I'm not sure what you guys have available, but these models are all based, in the US at least, from companies that made their models on German skulls. And there's definitely some anthropomorphic differences between different ethnicities in the skulls of what we work with. So the third option that's become more popular for us is to do a 3D printed implant where we actually have a manufacturer print and design these implants for us. Now, it doesn't necessarily just need to be the internal orbit. I use a lot of these for the external orbit. This is someone with a polyether ketone implant I'm using to sort of build up her maxillary face, do some augmentation of the rim. And you can do this with a variety of different materials. I just showed you one that was polyether ketone, which is one of my favorites. It's it's pretty common in dental surgery. We can also use porous polyethylene. This is a prefabricated one, but these can be custom printed as well. And then you have rigid body titanium, which is not just a mesh, it's actually a pretty firm grid. A lot of this work you can be doing with the manufacturers, but there's a lot of free tools that you can use. This is a tool called MeshLab, which is what I use on a Mac. This is just me. It's about 3 times the speed, but just taking a model, doing some smoothing, doing some mirroring, and then you can just print this yourself. Or you can work with the manufacturers that are happy to do this work for you. They'll sort of design this over a virtual meeting with you, and you can demonstrate exactly where your implant is and help kind of design it. You can get a little bit more complicated. Here I'm doing something called hardware extraction. So this is a patient with a fairly robust zygoma fracture that was not reduced properly. He has a ton of titanium. We've taken this titanium out and designed a new implant to build up the malar rim rather than doing osteotomies. You can do something called a drill guide. In this case, when you're going to be putting an implant in, maybe the place where you're going to fixate is not super rigid bone, or maybe the shape is a little complex. And so in order to mark those 2 locations where your implant needs to be fixated, you can print something called a drill guide. The drill guide goes onto the rim, you fixate the one pre-drilled screw hole, and then you do some drilling through these tunnels, and so you know the trajectory of where you're going to place your implant is exactly where you want it to be. And like I said before, you can do some prints. This is a woman who had a large craniotomy, and they took her sphenoid wing off. We went back years later and did a peak implant. You can see it going in there. And you can really be helped with these acrylic models to figure out exactly where the defect is along the skull. This is something called volumetric analysis. So we're going to look at the orbital volume. This is a patient with maxillary atelecticus or sinus syndrome. And we're going to design our implant, and then we can calculate that the new orbital volume we're going to have afterwards is exactly symmetric to the other side, or at least as close as we think we can get it. This is a woman with a large maxillectomy. And again, I'm just showing a few different techniques. Here we see the pre-drilled implant. You also see I've planned out where to place a plate for the medial canthal tendon after the surgery. She has, in this case, fairly profound enophthalmos, and we know that she's had a pretty large cancer resected from the lacrimal sac, so she's not going to have any tear flow. So we also design a location to place a Jones tube once the implant is in place. You can get very creative when you're designing these. This is a gentleman with very profound proptosis. In his case, I thought taking the lateral walls off and advancing them might be helpful rather than just drilling the lateral wall and doing fat decompression, but his globe is outside of the orbit. And so we actually designed an implant that is not just a new orbital wall more forward, but it actually is further out, which pushes the temporalis out of the way. We call this an orbital cage, and it's a very large implant. You can see it's complicated to put it in, so I create a pre-cut cut guide, which goes over the orbit, and I cut on either side of this, and then we have this large implant. We take the bone flap out and put this large implant in. And this is him actually just a couple weeks after the surgery. We're still working on this particular gentleman, but you can see where the implants are going back. Navigation is something that we use a lot in various sort of oculoplastics fields that work with us, like neurosurgery, ENT. It's really common to use navigation. What we use typically is navigation for surgery with our colleagues intraoperatively. But there are also a lot of interesting things you can do pre and post-operatively when you're navigating. Navigation is not complicated. It's the same as the way a Wii works. You have an infrared camera and 2 infrared lights, and it knows your position in space because of that. In the operating room, they actually double it. You have 2 cameras, and then you have a variety of infrared bulbs that the cameras can see. Some are mounted to the patient, and some are mounted to the surgeon. This is the technique that I use. Rather than try to fixate the head, we use something that involves about a 0.5 centimeter incision and 1 single 4 millimeter long screw. This is called a fixation array. You hook this up and then you attach the array. Now we have the array attached to the bone. We have to then do an infrared scan of the soft tissue because the computer knows where the soft tissue is. Once it figures out where the location of the soft tissue is, it knows, well, I know where that is. Now I know where it is in space, and I know where that array is, and it now can allow us to navigate. And you can see me here operating with the navigation screen just right in front of me. You can use it for intraorbital surgery. Here I'm just sort of demonstrating using it for a DCR, which is another technique. It's maybe not necessary, but it's always helpful for. What we just described was line of sight, but you can also have the navigation be without the need for cameras. This is an electromagnetic method. Unfortunately, our metal instruments interfere with this technology, so this is not my favorite. And I mentioned with some of our colleagues, they'll pin the head rather than actually put a little screw in, they'll actually pin the head. You have to scan the patient with some markers if you're going to do that so that the scan knows where you are. Now that's all basic sort of intraoperative navigation, but I very commonly will use some of the more advanced tools that go along with the navigation package for some pre and post-operative assessment. And really the interesting thing you could do is create models. So here I've created some models for a very large orbital decompression, but this is just an example of an orbital tumor where it's not very complicated. It's a benign mixed tumor. We're going to go and take this out, but he's got an area with dehiscence along the roof. We're going to do this maybe in a surgery center. We don't necessarily want to have violation of the dura. And so we'll mark out where that hole in the roof is. And then during the surgery, the suction might beep every time I get close to that. It just gives us a little bit of an additional tool. It's helpful for people who are learning. You can get a little bit more fancy. Here's a gentleman with a large cavernous hemangioma. We can calculate the size that we're going to be needed for our osteotomy to make sure that we can get this large hemangioma out. This is just a video. We take a standard canthotomy approach. And then I don't know if you have this, but we like a cryo probe to remove these kinds of lesions, which is a really nice way to get these out. This is a gentleman with a much larger hemangioparasitoma. This gentleman was in his 90s, and this is really a palliative resection because this was a recurrence. But again, you can calculate the size of your osteotomy, which you can see in blue, that it's going to be big enough to remove this whole tumor. In this gentleman's case, this is going to be too big to get out without getting into the rim a little bit. This is another example, just a large tumor. We're just calculating the size of our osteotomies. In this case, it was a very, very large recurrent benign mixed tumor from a patient who came overseas, and we're just taking this out through a lid crease incision. Now, beyond the sort of use to measure and mark things, we can also create objects to use during the surgery, to navigate during the surgery. So here's a gentleman with a pretty profound right zygoma fracture. And what I've done here is made a model of the left orbit, maxilla, and zygoma, mirrored it to the other side. So we have now the bad zygoma and a ideal mirrored zygoma. And we can see what that looks like from below. The zygoma is pretty severely impacted. We can see where our new zygoma position really should be. And we can bring this model into the operating room in a navigation device. So while we're doing our surgery, we can use our markers or our navigation wand to sort of design, okay, here we've repositioned the zygoma. Is it in the right place? Are we happy with where it is? And you can see post-operatively that my zygoma ended up pretty close to where I wanted it to be. So the blue is where we wanted it to be, the white is the actual post-op scan, and the pink is where it was when we started. So this is a very depressed zygoma. We've put it pretty close to where we want it to be. You can see his soft tissue windowing there really demonstrates the effect of a zygoma fracture on the soft tissue of the face. But you know, a nice way to do these types of cases. Same thing with our orbital floor fracture repair, and I showed this exact case previously, and in his case I demonstrated in the previous talk about how we use these preformed plates and that each of them is a little different and they don't necessarily match up with the anatomy of every patient. In this particular case, I'm actually fitting all the different types of implants to see which one fits best. And in the end, they're not all the same. And I can pick one that fits as close as I can to the other side and then choose that one during the surgery. They're all too big, they need to be cut. And to save myself some time, I'll actually mark out where the fracture is and do a digital subtraction. And I can make a little template of exactly what I want the new implant to look like and just put that in during the surgery. It turns out there's only so many ways you can cut these. So I actually have a variety of cut models in the software that I just pull in. I pick which one I want, cut it during the surgery. This is what it looks like when it's implanted. And during the surgery, we have that new model in place. And so I can use my navigation to paint the inside of the orbit and make sure that my implant is correct. The alternative would be a CT scan, which exposes the patient to radiation and requires another set of technology, which we don't have. And so I'd use this as a sort of a cheap way of determining if I'm in the right place with my implant. And this is him postoperatively. And again, I like to assess with a postoperative scan. And here you can see that the implant was where I wanted it to be. It's a pretty close approximation to the other side. You can use this to design a lateral wall decompression. Here I'm just marking out the area of the lateral wall that I'd want to decompress. And you use, again, those models that kind of warp to the orbit. I'm doing a medial wall too. And you can even get fancy and mark out where the anterior and posterior ethmoidals are or the optic canal is if you're working with a trainee, because you might not be able to see in the orbit while they're operating. That way you can kind of get a sense if you're getting close to it. Here I'm just marking out the two ethmoidals. And then during the surgery, we'll make objects that beep when we get close by. You can get fairly far back along the optic canal if you're going to do a decompression anteriorly. And this is just drilling out the lateral wall. And then, like I said before, I really like to use these postoperative tools. So you can take your pre and postoperative scan. These patients were scanned as part of a study, but these are just decompression patients. But you can demonstrate by fusing the pre and the post-op images in these software where you've made your changes. If you're going to do something slightly more complex, like in this gentleman, I advanced the lateral walls. He had a fairly depressed lateral wall in the setting of Graves' disease. We made osteotomies and advanced the walls. This can get a little bit tricky, but if you do this postoperative fusion, you can see, okay, my orange is my new position, my blue is where it was. You can see what part of the lateral wall I've removed. You can see the new position of the lateral wall. It's a nice way of keeping you honest, making sure that the surgery you do is what you think you're doing. In certain times, you actually need this. So this is a gentleman who had a two-wall orbital fracture internally as well as a zygoma, and the plate was intraconal. This was not my postoperative result. And so what we did here is design a mirror image. The red is the target where we would like our new orbit to be. And you can see where the zygoma was in blue and where it ended up in orange. And you can see we got fairly close with our new implant, which you can see on the post-op scan, to the red orbital model. And in a case like this where you're doing an incremental surgery and it's a very complex fracture, this is a nice way to get as accurate a result as you can. Now, all that being said, this is only the bones, and I think the other elements of surgery for the orbit involve repositioning of the fat, making sure you preserve the tissues nicely. You have to deal with atrophy after trauma and things, but I really like to get the bones as accurate as possible. So this was my talk on navigation. I find these computer-assisted techniques are maybe a little bit more than you need for many cases, but if you're interested in this technology for more complex cases, using it and getting familiar with it for more simple cases can be helpful. And if you have access to some of these tools, they're great for people who are learning these surgeries and for really contributing to the field to understand what we do. So again, thanks very much for letting me present this work to you. Sure.